Okay, so these are what we call liver function tests, and probably the names are now familiar to most of you. We talk about the bilirubin level, and we talk about conjugated bilirubin and unconjugated bilirubin, and I'll go into that in a bit more detail in a minute. We talk about ALT and AST. I'll not even start pronouncing all these names. And we talk about alk-phos, gamma-GT, and albumin. And then we also talk about clotting, because the liver is involved in helping the blood to clot. And so we talk about the international normalized ratio, which is basically just the prothrombin time, which is a time, how long it takes for a certain cascade of clotting proteins to clot. And you can measure that against what is normal, and that gives you the INR, so 1. So if your clotting is normal, your INR is 1, because it's the same as a normal person. If your prothrombin time is prolonged, because you're not clotting very well, then your INR will be greater than 1. But I'll come through these individually. So I'm going to start with just bilirubin. And we all make bilirubin all the time. Is there a pointer on this? Or will something... Oh. Shouldn't have pressed that button. Right. Oh, here it is. So we all make bilirubin all the time. And it is actually a natural waste product of the breakdown of old red blood cells, which normally happens in the spleen. And the hemoglobin in red blood cells is broken down to produce bilirubin. And that type of bilirubin is what we call unconjugated bilirubin. And it tends to be, it's not water soluble, so for it to get from the spleen to the liver, it joins on to albumin in the blood to get it there. And this is the type of bilirubin that is produced in normal newborn babies, because they break down more red blood cells just after birth. So the normal baby bilirubin is unconjugated bilirubin. It then goes in the bloodstream to the liver, and it gets into the liver cell, and it becomes joined, conjugated to this molecule, glucuronic acid, and that makes it water soluble, so that it comes out of the liver cell and into the bile. The bile is stored in the gallbladder, and then when food starts coming along the gut, the gallbladder squirts bile out to mix with the food. The bile contains the bilirubin, but this is the conjugated bilirubin, and it also contains bile salts, which is necessary to help you digest fat and food. So if you're a newborn baby and maybe you're breaking down more red cells than you should, you produce too much of this unconjugated bilirubin. But if you've got something wrong with your liver, then it's actually after the conjugation that the bilirubin starts to rise in the blood. So we talk about the two types of bilirubin. And if you've got raised conjugated bilirubin in the blood, we know it's liver disease. If it's raised unconjugated, it's not liver disease. So, this is the same again. So a normal baby jaundice, you have this raised unconjugated bilirubin. Because this isn't water soluble, it doesn't appear in the urine. So baby urine with normal baby jaundice is a normal colour, and normal baby urine is often almost crystal clear. And because the waste product of the bilirubin is coming out in the stools, then the stools are a normal colour. Whereas if you've got liver disease, then it's actually the bilirubin that's been to the liver cell and has got joined to the glucuronic acid molecule. It's the conjoined bilirubin that's raised. this is water soluble, so when it leaks out of the liver cell back into the bloodstream, it can get excreted in the urine, and so you can get a dark coloured urine. And because you're not getting enough bilirubin back into the bile and into the intestines, then the stools can become paler. And this is something that we look at closely in children who are diagnosed with liver disease in the newborn period, and to a certain extent in older children as well. And it may ring a bell with some of you from previous conversations. And that's just to prove what poo can look like. It's well, we've had our lunch. So this is normal coloured poo, and we say it should really be the colour of English mustard. And this is obviously paler. Get rid of that. And in babies, finding a raised conjugated bilirubin would make us think of any of these diagnoses. And obviously the one that we need to get out of the equation as quickly as possible is biliary atresia, because if we operate on those babies early enough, we may prevent them needing a transplant, particularly in infancy. In older children, you can still get raised conjugated jaundice with any of these conditions as well. I'm going to use this diagram then to explain about the other liver function tests. So it's fairly similar, except that the enlarged bit is as if you're looking down a microscope at the liver, and it's a bit like the picture. Wish I could have borrowed Richard's picture, actually. It was clearer. And you've got these rows of liver cells, and then in between the rows of liver cells, you have this little channel called the canaliculus. You've already met that this morning. And there are cells lining the canaliculus as it gets bigger into a ductule, and these are bile duct cells. And these little channels get bigger and bigger until they become not just ductules, but ducts, which are bigger than ductules. And then you get down to the common hepatic duct, and the duct going into the gallbladder, and then the common bile duct. So that's the pathway, and you've got two types of cells. You've got the hepatocytes, the liver cells, making the bile, and then you've got these little cells along the edge of the bile ductules and ducts called cholangiocytes, or bile duct cells. And so the different proteins that we measure in the blood leak out of different cells in that pathway. And first of all, we talk about the transaminases, the ALT and AST. And they leak out of the liver cells. So anything that irritates the liver cells can make your transaminases go up. They're terribly sensitive, and they will go up even in you or I if we have a bad enough viral infection. But they are mainly based in the liver cells. That would be nice if that was the only place they were based, but of course that's not necessarily the case. ALT tends to be a bit more specific to the liver, although it can be produced in muscle cells as well. AST is also found in other cells throughout the body, and therefore it tends to be a little bit less specific to the liver. And as I said before, they're very sensitive. If you get an acute infection of the liver, like hepatitis A or acute hepatitis B, they can shoot up to the thousands very quickly. Similarly, with a paracetamol overdose or autoimmune hepatitis, they may shoot up very quickly. After a liver transplant, again, they may shoot up very quickly and quite high if, for example, you get a clot in the artery taking the blood to the liver, which can sometimes happen in the immediate post-transplant period, or even with an episode of rejection. And these very acute high rises do not necessarily signify that the liver's not going to completely come back to normal again. They just tell you there's been a very sudden insult to the liver. And then we have sort of grumbling variability of the ALT and the AST. And that's what we see in some of the chronic liver diseases that we look after. So a child who's had a Kasai port enterostomy for biliary atresia, their ALT quite often doesn't completely come back down to normal afterwards, and it kind of grumbles in the hundreds. And similarly with alpha-1 antitrypsin deficiency or Alagille syndrome and PFIC, a lot of these conditions, you'll just have that slight grumbling rather than very high peaks that you might get in these acute infections. And in those conditions, they don't always tell us very much about the progression of the liver disease. Where the ALT and the AST come into their own for monitoring is in these two conditions. So in autoimmune hepatitis, where the body's immune system has failed to recognize the liver as being part of the body, and therefore has started producing antibodies to the liver and attacking it as if it was a bug or a virus. In that situation, we put the children on immunosuppression treatment, a bit like we do post-transplant. And as things are improving, we will usually monitor particularly the ALT or AST to see that we're getting things under control. And it's a useful tool to monitor those. And when we get things under control and the ALT comes down to normal, a blip might mean that we've not got enough immunosuppression on board, or that they've had an intercurrent infection or something like that. So it's quite useful in that scenario. And similarly, post-transplant, we've mentioned about the sudden rises with blocked vessels and rejection and infection. But again, you'll be coming to clinic and your ALT will be measured and it's usually normal, and then it maybe goes up and it goes up a wee bit more. And so we'll say to you, oh, we're not sure if it's rejection or a bit of infection, you better come in for a liver biopsy. So that's the use of those two. Then I've moved on to the alkaline phosphatase, ALK-PHOS, and gamma-GT. And these are what we call the biliary enzymes, because they tend to leak out of the little cells lining the bile ducts. And so if they're raised, it would suggest that there's something irritating the bile ducts. ALK-PHOS is less useful, particularly in children, because again, it's found in lots of other parts of the body, and particularly in the bone. And children are growing, they go through spurts of growing, and so sometimes the ALK-PHOS is high because of that. And so we'll keep an eye on it, because of course it can go up also with something like rickets. But we use the gamma-GT perhaps being more specific to the liver. As I've mentioned, ALK-PHOS can be up for other reasons and is therefore a bit less useful. And so we go with gamma-GT. And you will notice that in children with biliary atresia, in children with Alagille syndrome, sclerosing cholangitis, anything blocking the bile ducts, gallstones, the gamma-GT tends to be quite high. It's also useful, and you've heard about a child with PFIC already today, and one of the usefulnesses of gamma-GT is that although PFIC is a child with cholestasis, i.e. they have high circulating bile salts, they're jaundiced, they're itchy, they have all the symptoms of a blockage to bile flow. The blockage is actually in the pathway between the liver cell and the bile duct, so they don't actually get a high gamma-GT, and this is quite useful to us in diagnosing these children. Sometimes with drug reactions this happens as well, and the very rare inborn errors of bile salts where you're not making the right type of bile salt, that can happen as well. So gamma-GT has its uses too. And then we talk about synthetic function, and that's because the liver makes proteins, and the two proteins that it makes are albumin and clotting proteins. And so you'll hear people talking about they've got good synthetic functions. That means that the liver disease is still stable enough that they're able to make the proteins that they should be making. Albumin is a protein manufactured by the liver, and its purpose is it keeps, you may know the term osmotic pressure, it keeps the fluid component of blood within blood vessels. And it also binds to other substances in the blood, like bilirubin, like some drugs. And if the albumin level falls in the blood, then the fluid within the blood vessel can leak out of the blood vessel into the tissues, so they get puffy eyes, puffy legs and feet, and that's called edema, or it can leak into the abdominal cavity, and that can add to the presence of ascites. It's not the only reason you get ascites in liver disease, but it does add to it. But the trouble is that albumin can be low for other reasons. In liver disease in particular. You can get a low albumin because you're not eating well, you're vomiting, you're malabsorbing, and you're not getting enough protein into your system. So that's malnutrition and malabsorption. Or perhaps you're getting enough protein in, but the liver is not able to synthesize that protein into albumin. And that's when we talk about lack of synthetic function. Or occasionally it's because you're losing too much albumin, either because the child has started to have diarrhea and they're losing protein from their gut, or perhaps just incidentally they're losing protein from another source like the skin in burns, or through the urine if you have an associated renal problem. And then finally the clotting. So again, clotting proteins are manufactured in the liver, and they're manufactured from vitamin K. And we get vitamin K from our diet. We can't store very much vitamin K in the body, and therefore you can run out of it as one of the earliest vitamins that you run out of if you're not able to digest fat-soluble vitamins well enough. The prolonged prothrombin time just means that it's taking longer for the blood to clot. And I've said that before. And that can be for two reasons. It might be because you're not producing enough bile salts into the gut, and you need the bile salts to digest fat and fat-soluble vitamins. So if you've got biliary atresia or Alagille syndrome or PFIC, where there's not a good flow of bile into the gut, then you won't digest fat well, so you may not grow well, and you won't digest fat-soluble vitamins well, one of which is vitamin K. So the vitamin K will not get into your bloodstream to go to the liver to make clotting proteins. So the first thing we do when somebody comes with a prolonged prothrombin time is give them a dose of intravenous vitamin K to bypass all that malabsorption, give the liver vitamin K via the bloodstream, and then we can see, is the problem that it's malabsorption, and so the clotting time will come back to normal within a matter of hours, actually. I have seen a child go from a prothrombin time of about 120 seconds due to just malabsorption of vitamin K completely back to normal within a few hours, just because they hadn't enough vitamin K in their system. But if it doesn't come back to normal after giving the intravenous vitamin K, then that means that the liver no longer has its synthetic capacity. It can no longer make the clotting proteins out of vitamin K. And that is usually a sign that liver disease is advancing. And because the synthetic function is one of the last things to go when you've got liver disease. So that's just a picture again of all the liver function tests. I'm not sure if you want questions at this stage or whether you want to leave them all to the end.
We'll do questions at the end.
Yeah, okay, Thank you very much.